Morning to everyone, and I'll be presenting my topic on vascular targeted therapies for liver fibrosis. These are the contents of the slides, which includes an introduction, basic mechanism of angiogenesis, proangiogenic factors, whatever is new in the last 2 years, as well as the conclusion. So before we get on to the angiogenesis part, a brief introduction on fibrosis, which basically means excessive accumulation of extracellular matrix leading to a chronic non-resolving inflammation. This inflammation triggers a healing process, which however leads to a scar tissue formation. There's a continuous remodeling which happens, and the most important part of the fibrosis is the hepatic stellate cells. So coming to this diagram, which basically depicts the hepatic stellate cells as well as the endothelial cells with the macrophages, it is the activation of the hepatic stellate cells as well as then activating the myofibroblasts, which in turn activates the macrophages, thereby leading to this cascade of liver fibrosis. All these markers that you can see here basically contribute to the pro-fibrogenic environment that a patient with liver fibrosis is. And the ones which are marked in black are the ones which are basically pro-fibrogenic. So you would find TGF-beta, platelet-derived growth factors, you will have metalloproteases 9, and also VEGF. So these are some of the factors which have been implicated in patients with liver fibrosis and form a part of the pro-fibrogenic environment which a liver deals with. So as I had already discussed, the sinusoidal endothelial cells is one of the most important factors for liver fibrosis, and this slide basically depicts a slide where there has been a partial hepatectomy leading to the formation of endothelial cells, which first causes proliferation of the proximal hepatocytes, causing an inductive signal. Then they release an angiographin factors. By day 4, there's a significant increase in these sinusoidal endothelial cells, thereby causing a further support of these endothelial cells. Now coming to angiogenesis. Now pathological angiogenesis, irrespective of the etiology, is characterized by extensive and prolonged necroinflammatory and fibrogenic processes. Most of the pro-angiogenic factors are already shown, and liver-associated angiogenesis is one of the most promising intervention strategies, as well as one of the markers for early fibrosis, which has been a limitation for most of the markers which have been going around for liver fibrosis. So the first question that is to be asked is angiogenesis of liver a friend or actually a foe? So this is a slide which depicts the two main actors for angiogenesis, which includes inflammation as well as hypoxia. And there's a persistent tissue injury causing inflammation. The inflammation triggers an endothelial activation. The endothelial activation causes an increased permeability in chemokines, causing an angiogenic cytokine release. Also, hypoxia triggers HINF1 alpha, thereby stimulating VEGF as well as the other markers, there itself causing angiogenesis. Now coming forward to this basic mechanism of angiogenesis, the phases of angiogenesis are of paramount importance, and as you would see, the first phase of any angiogenesis is sprouting. And sprouting basically is that once there is hypoxia and there's a trigger, there is an excessive vasodilatation. This is where there's an increase in permeability and leakage, leading to the formation of VEGF. And VEGF has been implicated in cirrhosis and all other forms of liver fibrosis, which we will be discussing. This in turn causes a remodeling of the extracellular matrix. The extracellular matrix is then locally degraded, and then all the interendothelial cells are weakened, thereby itself causing proliferation and migration of these endothelial cells. You have activation of the VEGF, you have the TGF-beta, and also the fibroblast growth factor. That in turn causes a lumen formation and recruitment of pericytes, and lastly causing stabilization of these vessels. So the process starts with sprouting, where there is a formation of a new vessel. It causes a remodeling, and after the remodeling, there is a stabilization of this vessel. And this diagram very typically predicts where there is a pre-existing blood vessel. You can see here there's a tip cell formation as well as migration. There is a sprout formation, and that's where the stalk cells start supporting the stalk formation. There's a lumen formation, and lastly the vessel stabilization. So all the pro-angiogenic factors are either implicated in the sprouting mechanism or they are implicated in the stabilization mechanism. So these are the phases of angiogenesis, and all the stimulators of angiogenesis, namely the VEGF angiopoietin 2, which we'll be discussing later in details, the fibroblast growth factors, the TGF-beta, and all these factors are implicated in the various phases of these angiogenesis. So once there is angiogenesis in liver fibrosis, there basically is a profound change that occurs in patients with cirrhosis, thereby increasing the number of sinusoidal vessels of varying diameter and flow pattern. In fact, later there is also now the new role of portal angiogenesis, which is a newer formation of these. So coming to the specific angiogenic factors and the therapy which have been based on these, and the most important one, which is the vascular endothelial growth factor. The vascular endothelial growth factor has been there for a very long time. It has been recognized as one of the major pro-angiogenic growth factors. It causes extensive neovascularization in the liver as well as the mesenteric vascular bed. It causes an increase in the splanchnic blood flow, contributes to liver fibrosis, and is regulated by the Krebs proteins. Now, some of the studies on cirrhosis dates back to almost close to 2004 and 2005, and most of these were based on the animal models. And all of them have showed that cirrhosis per se, or liver fibrosis, causes an increase in VEGF, regulating the expression of the nitric oxide levels. There have been certain studies which have looked at the combined effect of VEGF as well as the platelet-derived growth factor. So this study had used rapamycin and Gleevec, which is imatinib, and they had shown that reduces the splanchnic neovascularization. And then you also have the anti-VEGF2 receptors, where there is a reduction in the portosystemic collaterals whenever there is blockage of these anti-VEGF signaling pathways. So this was a paper from ILBS where about 14 patients were studied with NASH, and they were looking at ductal reaction. And the salient feature of this was to identify markers for the early fibrosis and late fibrosis. And it was detected that VEGF levels were significantly increased in patients with the HU7 factor, and they were also increased in the EpCAM positive cells. So this also does show off that the angiogenic mechanisms of liver fibrosis are one of the earlier markers of fibrosis, and possibly leading to better detection and treatment for liver fibrosis. Now, coming to some of the treatment aspect, and one of the most commonly used drugs used for HCC is tyrosine kinase inhibitor, which is sorafenib. And sorafenib has an action which is on VEGF and all the other multiple pathways. And this study, which was done in 2009 in hepatology, had actually shown that there are differential effects of sorafenib on either liver fibrosis or on the HCC part of it. And as you can see here, when sorafenib acts on liver fibrosis, it causes a decrease in differentiation, a decrease in proliferation, and an increase in apoptosis, thereby causing decrease in fibrosis. On the other hand, when it is actually given for patients with HCC, if there is a blockage of the stromal derived factors, it actually causes an increase in differentiation, an increase in proliferation, thereby decrease in apoptosis. So sorafenib was one of the earlier drugs that have been used for patient liver fibrosis, though all of these studies were in mouse models, but it does show that it has dual effects on both liver fibrosis as well as on hepatocellular carcinoma. The other drug that has commonly been used, and there have been few studies, is bevacizumab. And bevacizumab is an anti-VEGF medicine which has been given, and this trial was again published in 2014, which looked at the use of bevacizumab, and this basically blocks the VEGF receptor, especially type 2 receptor. And here they had seen that in patients who had received bevacizumab, there was a reduction in the ALT levels, there was a reduction in the bilirubin levels. It also caused a destruction of the alpha myoctin levels as well as the TGF-beta 1 levels, thereby indicating that bevacizumab could potentially be one of the agents for the reduction of liver fibrosis. The other which has been used is brivanib, and brivanib is again an inhibitor of the FGF as well as the VEGF and the PDF growth factor signaling. And this study had shown that brivanib, when given in doses of 25 mg per kg or at 50 mg per kg, had shown a reduction in bridging fibrosis, as well as there was a reduction. As you increase the doses of brivanib, there was actually an increase in adverse effects, hence the 100 mg one was not used in this case scenario. The other case is a recently using technique, which is the short interfering RNA technology. So A is the therapeutics, and the second is the delivery system for liver fibrosis. And this again was a study which showed the endothel KDR, also called the VEGF2 receptor. Once you target it using the short interfering RNA technology, using the lipoplexis, it actually acts on the vascular endothelial cells, which in turn act on the mesenteric microvesicles and the portal vein, thereby causing a decrease in the portosystemic collaterals. So again, the blockade of VEGF using a newer technology of short interfering RFA technology has been shown to reduce portosystemic collaterals and possibly again forms a future therapeutic intervention in patients. Coming to the next one, which is the platelet-derived growth factor. And the platelet-derived growth factor is basically where the upregulation in the mesentery occurs. There are endothelial cells, which then cause the initiation of the pericytes, thereby causing the vascular architecture. The reason why platelet-derived growth factor has been important is because, as I discussed earlier, VEGF is involved in the initial formation of the blood vessels, formation of the endothelial tube, and the sprouting, as I discussed. Platelet-derived growth factor acts on the later stages of angiogenesis. So it acts on the stabilization of the endothelial tube. It also stabilizes the membrane which is formed. So the combination of VEGF and platelet-derived growth factor theoretically has been of immense importance in patients of liver fibrosis, and that is why the earlier study where they had used imatinib plus rapamycin, which had certain implications in patients with liver fibrosis. Some of these other studies where they had used sorafenib as well as sunitinib had shown that it inhibits both VEGF as well as the platelet-derived growth factor. It also causes the RAF signaling pathways, reduction in portal pressures, as well as a decrease in the inflammatory infiltrates, collagen expressions, as well as the portal pressure. So both these mechanisms basically discuss the fact that if you combine both the aspects of VEGF as well as the platelet-derived growth factor, there can be a decrease in the angiogenic pathway of liver fibrosis. The placental growth factor. Now the placental growth factor belongs to the VEGF family. And the most important part of placental-derived growth factor is that it is only activated in pathological conditions, whereas the other two that I discussed can also be activated in normal physiological conditions. And the most important function of the placental-derived growth factor is to actually bind to the VEGFR type 1 receptor, increase the tyrosine kinase activity, that is by competitive binding to the type 1 receptor, thereby increasing the efficiency of the VEGFR type 2 receptor. So the implications of such has already been studied, and this was studied in patients with hepatopulmonary syndrome. And in hepatopulmonary syndrome, in this study, they had shown that the placental growth factor inhibition actually is involved in the pulmonary angiogenesis, as well as if you blocked the placental-derived growth factor, which they had done using this IgG immunoglobulin, which is the PAGF production, it actually caused a decrease in pulmonary angiogenesis in patients with hepatopulmonary syndrome. So this again, even though these are still in vitro and in vivo models, also represent another aspect of angiogenesis in patients with liver fibrosis, specifically in this case with HPS. The other pathway, which is the angiopoietin pathway, and this is one of the very important pathways that are also being implicated in other studies, especially in Crohn's disease, ulcerative colitis, because angiopoietin is one of the most important factors which govern the angiogenic growth as well as the remodeling. There are 4 types of receptors. I mentioned 1 and 2, but there are actually now 3 and 4, and they both are agonist and antagonist to the Tie ligands. They control the vesiculations in adults and also regulate the steps of angiogenic cascade. In the best way to remember an angiopoietin is it is a gatekeeper of all the cytokines that are released during an angiogenesis. So if you look at the short term and long term, so if somebody has an inflammation, the common problem is rolling, triggling, firm adhesion, and transmigration. So if you have an angiopoietin, the angiopoietin here is extremely important in keeping the control of how much amount of cytokine release or the chemokine release which occurs. It maintains the process of triggering then to form adhesion, as well as the formation of the adhesion molecules, which include the ICAM and VCAM. So it has a very important role in mediating inflammation and, as I said earlier, as a gatekeeper of all sorts of cytokines which are released during inflammation. When you look at its long-term aspect of tumor initiation, so whenever a patient has development of tumor, there is something called as an host vessel cooption, where there are new vessels which are being formed with pre-existing vessels. This is mediated by the angiopoietin. The angiopoietin in turn causes the vascular destabilization as well as the vessel regression. Now once the vascular regression occurs, there is going to be hypoxia, there's going to be an avascular tumor formation, thereby causing an increase in the VEGF pathway. So the whole cascade of VEGF is then activated. So it is the angiopoietin which actually regulates the formation of VEGF and thereby the whole process of angiogenic sprouting, as well as the later formation of the angiogenesis, as well as the stabilization which occurs in the end of all angiogenic processes. So angiopoietin 2 has been studied in patients with liver cirrhosis and also hepatocellular. This is a very old study in 2007 where they had actually retrospectively analyzed 131 patients, and they had shown that angiopoietin 2 levels were increased in patients with cirrhosis and even further increased in patients with hepatocellular carcinoma. And they had shown as the child status increases, there's a sort of an increased levels of angiopoietin 2, thereby triggering this whole theory that angiopoietin can actually be one of the markers for liver fibrosis, or namely an early marker of liver fibrosis. So the therapeutics of angiopoietin has been recently studied, where they have actually looked at therapeutically targeting these angiopoietin 2 receptors in a murine model. And they have shown that if the angiopoietin 2 receptors are blocked, it actually causes a reduction in the hepatocyte ballooning. It causes a reduction in fibrosis. It also causes a reduction in the hepatic angiogenesis, normalization of the vascular microarchitecture, as well as it mitigates the increase of cytokine production. So it is, in and all, it almost targets all the mechanism of angiogenesis that have been discussed at present. So angiopoietin in itself is one of the main targets of the pro-angiogenic therapies that are being postulated for patients with liver disease. So some of the drugs that have been used for treating liver fibrosis, most of the drugs are in the murine or in the mouse model, which commonly include sorafenib, brevanib, as I had shown. Imatinib has been seen in certain patients. You also have a statin, which is simvastatin, and simvastatin actually downregulates the KLF2 path and has been shown to have some efficacy probably in HPS and in pulmonary angiogenesis. You also have rapamycin, thalidomide. So most of these are still in experimental model. We still do not have drugs which are actually treating the liver fibrosis. So the formation of the creation of new drugs are important, and not only that, the pathways of finding out angiogenesis is extremely important. So the next part is what has been happening in the last 2 years, and what is important is that the discovery of a new receptor, which is the leukocyte cell-derived chemotaxin 2. And this receptor is known to be a functional ligand. So if you can see this diagram, this is a normal hepatocyte. And you can see that the leukocyte cell-derived chemotaxin 2 is actually based as a functional ligand in the orphan cell, which is a Tie1 ligand, again, which is related with the angiopoietin system. The leukocyte cell-derived chemotaxin 2 actually inhibits the portal angiogenesis, which has never been implicated in patients with liver fibrosis. This represents a newer mechanism. As well as it promotes sinusoidal capillarization. So it increases the sinusoidal capillarization which occurs, which has been known in patients with angiogenesis. This in turn causes an increase in the liver fibrogenesis. How does it do that? It basically causes the dephosphorylation of the Tie1 ligand and the phosphorization of the Tie2 ligand. It also activates the MAP kinase pathway, the PPAR pathway, the cadherin signaling pathway, and also causes an inhibition of the EC migration as well as a tube formation, which was, if we have noted, was the second part of any angiogenic mechanism. So the discovery of this receptor has actually led to a very recent study published about last month, which was published in Hepatology, where they had looked at a strategy where they had looked at blocking the chemotaxin 2 mechanism using the adeno-associated viral vectors, and they had also used bevacizumab, and when they used the 3 combination of the adeno-associated viral vectors, as well as the VEGF as well as bevacizumab, they actually reported more adverse events. But when they used a combination of the vector as well as the bevacizumab, then they showed better improved therapeutic effects and decreased side effects. So maybe the future of targeting angiogenesis lies in the combination of treating this leukocyte chemoattractant 2 receptor as well as possibly bevacizumab, which is the VEGF pathway, which is basically blocked by this. The other is another study which was published very recently, where they have looked at targeting angiopoietin 1 as well as the von Willebrand factor. And I think 2 factors that have probably been studied but have not been put into interest is von Willebrand factor and as well as the ADAMTS. and this could be things that could be done in the future. And where they had looked at blocking angiopoietin 1 and von Willebrand factor, and then they showed that the protein levels of angiopoietin 1 and von Willebrand factor reduced. They showed that there was an attenuation of the liver angiogenesis as well as the liver fibrosis. They had also shown that there is an activation of the liver sinusoidal endothelial cells. So they had shown that once the angiopoietin 1 and von Willebrand factor expression increases, there's a negative correlation with the activated endothelial cells. So this possibly represents another mechanism. And as I had already discussed, that von Willebrand factor and ADAMTS possibly represent another mechanism of liver fibrosis. So when we look at way forward, actually ADAMTS was discovered in 2007 in patients with hepatic stellate cells, and the origin of ADAMTS has been implicated with patients with hepatic stellate cells. The problem is that it is still a very non-specific marker because it can also be reduced in patients with liver failure, sepsis. So the specificity of these markers is question, but these are definite markers which can be studied in patients with liver fibrosis and then in turn therapeutic agents. As I had seen that there was a study with simvastatin or statins, which are commonly used. So possibly statins in patients with liver fibrosis and their implications could be one way forward. The other would be the delivery systems. And I think most of the studies in the last few years have concentrated on the delivery systems of targeting these angiogenesis. And I think that is one way forward in these patients. So coming to the conclusion that angiogenesis is actually extremely crucial for patients with chronic liver disease as well as liver fibrosis. It possibly represents one of the earliest markers for liver fibrosis, as well as targeting it early possibly represents one of the best markers at present for liver fibrosis. And future studies need to focus on the angiogenic markers for the early identification as well as therapeutics. Thank you.